Welcome back. My name is Cecile Rooker. I'm the president and executive director for the International Foundation for Gastrointestinal Disorders, or IFFGD. This week, we are looking at the many GI symptoms that you might be experiencing, things that may have you alarmed, things that you're just not sure if you should be concerned about. And so we already talked about upper GI symptoms, and we've talked about mid GI symptoms. And so today we're going to talk about lower GI symptoms. We hope that you will enjoy today's program. We're covering a lot of material, things that might seem really common, but the speakers today are going to be able to explain to you when you should be concerned, when you should go to your doctor, and what should you talk to them about to make sure that you are comfortable with where you are and that there's nothing really seriously wrong with your body. Um, as you can see, we are in beautiful Boston here for this program, and I am just thrilled to be able to work with 4 different hospitals that are affiliated with Harvard. They are Mass General Hospital, Beth Israel Deaconess Medical Center, Mount Auburn Hospital, and Brigham and William Women's Hospital, all right here in beautiful Boston. Together with me here today is Kyle Stoller, who's the director of the Motility Lab at Mass General. And then we've got Brad Kuo, who is actually only here with us in Boston for a little while longer. As I mentioned, he'll be moving to New York. But these 2 wonderful, wonderful doctors and friends of IFFGD have really put together this great program for you this week. And so we're going to let you learn all about lower GI symptoms. And then we're going to come back and I'm going to ask these guys a couple questions just to make sure we've got everything buckled down about lower GI disorders. However, if during this presentation, during this recording at any time you have questions, jot them down and shoot them to us. Our email is iffgd@iffgd.org. In the meantime, enjoy today's program and make sure you stay in touch.
Hi, good morning, everyone. My name is Samantha. I am one of the nurse practitioners that works at Mass General Brigham over in Boston, and I'm here to talk to you today about constipation. So we're going to have a good talk about what constipation is, the types of constipation we see for patients, the causes of constipation we see for patients, testing we do for constipation, possible treatments, and of course, alarm signs, when to reach out to your provider if you have any concerns about your health. And so I want to start by defining constipation because constipation actually has a lot of different definitions, and there's not one perfect way to describe constipation. So I've put together a few different ways that we talk about constipation with our patients. And so when we're talking about constipation, we're thinking of infrequent bowel movements, difficult to pass bowel movements, hard, dry, or lumpy bowel movements. And when we talk about constipation, we think about generally this means less than 3 bowel movements a week, but this can also vary as well. We think about the difficulty it takes to have a bowel movement. So that's how we describe straining with bowel movements. And we also think about incomplete evacuation, which means despite having a bowel movement, you actually don't feel like everything has come out. And so when I talk about constipation, one of the first things I pull up in a visit with a patient is what we call the Bristol Stool Form Scale. And the Bristol Stool Scale really helps us work with the patient to understand what our stool looks like because that helps us define constipation, just like I was talking about. So generally, we think about constipation as type 1, type 2 Bristol stool, even a little bit of type 3. The bottom types of bowel movements that we see on the scale are really more related to diarrhea, so we won't be addressing that today. But when we think about constipation, when I was talking about those small, hard, lumpy stools, that can really be type 1 Bristol stool, those small, hard, difficult to pass pebble-like stools. Then we have type 2, where some of these harder stools are formed together, but they still can be on the harder side, difficult to pass. And type 3, again, a little bit better, a little bit more formed, but still on what we would kind of describe as the lumpier side. We do aim to range around a type 3, 4, and 5 to some degree when we're thinking about our stool variability, but again, everybody is different on that. And so I would like to start by talking about the different types of constipation. So we defined constipation and we did encompass all of these different types of constipation in our definition, but generally when I meet with a patient, I often discuss that constipation is not, again, just one linear definition, and there's different types of constipation. And so when I speak to patients, I talk about slow transit constipation. The way I describe slow transit constipation is you think about a train needs to make it from point A to point B in this particular time frame. And unfortunately, along the way, they meet some slowdowns. And so throughout their track, they're slowing down more than they thought they would. And so it takes longer for that destination to be reached. And that's how we describe slow transit constipation. Dysenergic defecation is really a term that's used to describe pelvic floor dysfunction or a little bit of difficulty evacuating stool. So the way I try to talk to patients about this is we all have a pelvic floor. It's made up of muscles, and that helps really hold our core and our entire bottom half up and together. And so these muscles help us really stop having bowel movements when we're not supposed to be. When we're sitting, when we're standing, when we're not in the bathroom, not having that urge to have a bowel movement. And sometimes those muscles become too tight. And so when we're ready to have a bowel movement, we're sitting, we're in the proper toilet positioning, which I will discuss a little bit later. But despite that, the muscles are not coordinating and not relaxing to help us have a bowel movement. Sometimes I'll describe this to patients as the doors open a very small amount and you're trying to get out of that door. But what's in there is too big to get out of that small little opening of the door. And that's what's happening with our bowel movements. Irritable bowel syndrome with constipation, or IBS with constipation, does encompass a majority or a variety of our constipation patients. And so when we think about irritable bowel syndrome with constipation, we think a lot about pain, primarily, that is associated with bowel irregularity. So think about that Bristol stool scale that I just showed on a previous slide. When you have those type 1, type 2 Bristol stool scales, and before you have a bowel movement, you start to get a lot of lower abdominal pain or just abdominal pain in general. And then you have that type of bowel movement. The pain generally improves after you've had that bowel movement, but that is what we also describe as irritable bowel syndrome with constipation. A lot of pain and discomfort with defecation or having a bowel movement. Chronic idiopathic constipation is really descriptive of probably what we've left out of those other 3 descriptions, and it's just irregularity of bowel movements, hard, difficult to pass bowel movements that don't really meet a definition for slow transit. So things are appropriately moving from point A to point B in an appropriate time frame, but there is still hard or difficult to pass stool. And then we think about secondary causes. Secondary causes can range from anything from the medications that you take to the other diagnoses that you hold as a patient. So this can range from medications of a particular class that can cause constipation. Pain medications can often cause constipation. And there's other neurological disorders that can cause constipation, just to name a few different things that might be secondary causes of constipation. What I would like to spend time on today is really how to discuss constipation with your healthcare provider. So I just reviewed the ways that I explain constipation to patients and how I help patients understand where they fall in that constipation spectrum. Now, how can you present your case to your healthcare provider? So what we like to know, and this is helpful based on what I just described previously, is how often you are having bowel movements. The consistency of your bowel movements. Are they hard? Are they small? Are they longer but still hard? That's where our Bristol stool scale comes in, and that's why I bring it into my patient visits, because I think it's important and easier for patients to have a visual representation of what they generally see. We also like to know what happens around bowel movements. Are you having pain? Do you feel like you're pushing really hard to have a bowel movement? Do you feel like your bowel movement is complete and you feel great afterwards, or is it actually incomplete and you're not feeling so good afterwards? Is there bloating? Are there other symptoms associated with bowel movements like nausea? Is there bleeding, right? These are some features that we like to know if they exist when you're having bowel movements. We also like to know how long your constipation has been happening for. Have you had constipation dating back many years? A lot of times, patients will come in with parents who say, "You've been constipated your whole life. You've had this since birth." Other times, we have patients who feel like this is a new onset over the last several months. That helps us understand perhaps the differential diagnoses we are thinking of. We also like to know what makes things better, what makes things worse. Does exercise help you have a bowel movement? Water intake? Does diet make a difference? What things have you recognized that maybe change the way you feel around your bowel movements? We also like to know things that you've tried. The worst thing we can do is have a patient, say, "Oh, I haven't tried X, Y, or Z, but I have tried this." And then we go and recommend something that you've already tried, but we've already known it's failed. So we like to understand what you've tried before, so that way we can help adjust your treatment moving forward. I just thought it would be nice to talk about a patient example that I hear often in clinic. That way we have a way to describe, this is what happens for me. So patients will say, "I've been having trouble with constipation really over the past few months. I usually have a bowel movement every 4 to 5 days. When I go, the stool is really hard and small. I'm straining a lot. Sometimes I feel like I haven't completely evacuated." They tried fiber, they tried increasing their water intake, but none of this really helped. Generally, that will prompt me as the provider to ask some additional questions, but we have a foundation of what this patient has been dealing with over this period of time. I would also like to take a moment to talk about some causes of constipation, right? And this list is definitely not all-encompassing of things that can contribute to constipation, but it's important to remember our diet does matter, and lack of fiber in our diet can really impede our bowel movements. In addition to that, we also think about hydration. These are general lifestyle modifications that are most often good for a variety of health conditions and also including your constipation. We like to make sure you get the water intake that you need. Physical inactivity can be a contributing factor to constipation. Now, everyone has different various ways that they exercise and move their bodies. A walk matters. Taking the stairs matters. Those little things do help just move your body, which then also helps move your bowels. Ignoring bowel urge, and this is surprising. This is one that I do hear often where, maybe you were a younger child in school and it felt embarrassing to raise your hand and ask to go to the bathroom. And so you kind of ignored that urge throughout the day. And eventually that urge may go away. You may not get that urge again for hours later. And so that tells the body, this isn't something that we need to do. And so ignoring that urge can then increase the amount of time between bowel movements and contribute to constipation. Medications, like I talked about secondary causes. There are a lot of groups of medications that can contribute to constipation. A lot of different medications have a lot of percentages of what causes constipation, but there are general groups that your healthcare provider likely will talk to you about that, oh, maybe this medication, you may see a trend towards constipation. And other medical conditions, like I mentioned previously, can play a role in how our motility or the way our stool moves through our body can work. When we think about testing for constipation, again, there are a variety of different tests for constipation, but I think it's also important to make sure you talk to your healthcare provider about which tests are important for you. I think the other thing with constipation is you don't always need a test to be diagnosed with constipation, and I do want to stress that because things like colonoscopies, for example, which is on this list, you don't need a colonoscopy to be diagnosed with constipation. Generally, you need your colonoscopy, of course, for screening purposes, but also if there are any concerning features surrounding your constipation. I do have a whole list of what those features are later on in this presentation, but generally speaking, a few things we think about include bright red blood with bowel movements, dark or black bowel movements, weight loss that is unintentional, meaning you weren't trying to lose that weight. That's generally when we bring in a colonoscopy and we're trying to rule out other causes of this. An abdominal x-ray is a great tool that we use in clinic, particularly a SITS marker study. A Sitzmarker study, which is shown on our slide here, is a study that actually evaluates for that slow transit constipation aspect that we talked about earlier. So what happens when someone has a Sitzmarker study is they swallow a capsule that contains 24 Sitzmarkers. And they swallow that capsule, and about 120 hours later, or 5 days later, they'll get an abdominal x-ray to see how many of those remarkers are remaining. If there's more than 5 markers, generally we are looking at a diagnosis of slow transit constipation, because that means things are not moving in an appropriate time frame from point A to point B. The next test that we like to also look at for a lot of our patients is a balloon expulsion test, or what we call an anal rectal manometry. An anal rectal manometry really helps us understand how those muscles of the pelvic floor are working. Like we talked about, our muscles of our pelvic floor are working right now. We're able to control our bowel and our bladder right now. But sometimes those muscles are so tight, like I talked about earlier, that it takes a lot of difficulty to evacuate stool, despite being in the proper position, relaxing, and even having a good stool consistency. Those muscles still sometimes are not working with us. The muscles have to coordinate to help us also relax and push down to have a bowel movement. We don't want patients to sit there straining to evacuate. We want this to really come as a relaxation and naturally. And so this test really helps us understand what those muscles are doing, like I said. So for this test, a small probe is actually placed rectally, and we have patients do some pushing, some squeezing. We're measuring sensation. How quickly does it take for you to feel this balloon, as shown in the picture, that is pumped up? Do you feel it quickly? Do you feel it later than some patients do? This helps us understand the sensation that goes on in the rectum. And the pressures help us understand, is there so much pressure being used? Are we trying to overcome that muscle tightness? Or it helps us understand, are the muscles actually on the looser end of things? And so this test helps us understand if patients should pursue an additional treatment option called pelvic floor physical therapy, which I will talk about later. Similarly, a defecography can be done through an MRI or fluoroscopy, and it is another tool to look at the pelvic floor. The way that we tend to do it at our institution is we utilize barium that's placed rectally as well as vaginally if you are female. And what we see is we actually watch that process of having a bowel movement. What do the muscles do? Do they coordinate? Is there straining? Is there any leakage of stool? Are there any structural abnormalities occurring during this examination? And this again helps us understand if the pelvic floor muscles are contributing to constipation. I'm now going to spend a little bit of time talking about treatment. Again, treatment, as always, is best discussed with your healthcare provider, as they know your full picture and your healthcare needs. When we talk about treatment, we first want to talk about non-medication interventions, right? So we talked about what the causes of constipation were. That makes sense with this treatment. Dietary interventions, increasing our daily fiber intake, fruits, vegetables, oats, bran. You can always work with your physician or healthcare provider to talk about these options. Also, sometimes patients enjoy meeting with nutrition to talk about, are they meeting their daily fiber intake? Increasing hydration. We all likely could do better with our water intake. Hydration is very important. It gives the bowels and the colon what it needs to hydrate and keep that stool less dry. Remember, when we talk about constipation, we're talking about dry, hard, lumpy stool. We need that hydration to nourish the colon. And we like to exercise. We like to keep our body moving, which keeps the colon moving and improves motility. Another non-medication intervention that I like to talk about is pelvic floor physical therapy. Pelvic floor physical therapy, again, helps strengthen and relax appropriately those muscles of the pelvic floor. It allows those muscles to help us have an easier and more complete evacuation. You will work with a specific pelvic floor physical therapist who is well-versed in this area. And it's really more specific than just a general physical therapist. They are very focused on our pelvic floor. They generally use what we call biofeedback techniques, and this really helps us understand how to properly use those muscles in the pelvic floor. They're actually looking at what happens when you're pushing and straining, and they're giving you real-time feedback to help improve your toilet positioning, improve the muscles are in that area, so you're not exerting yourself a significant amount while you're trying to have a bowel movement. There's special sensors that are used during this technique. Patients also work with the provider on manipulation of those muscles if needed, and that can involve work with the provider on specific techniques. Cognitive behavioral therapy and gut hypnotherapy are also important interventions from a non-medication perspective, particularly for our irritable bowel syndrome patients with constipation. With this, we know the gut and the brain talk all the time. There's nerves throughout our GI tract that are signaled by the brain and vice versa. They're in constant communication. People really do say our gut is our second brain, and I think we really see that in our motility clinic where I am lucky enough to practice. And so we try as best as we can to refer our patients to cognitive behavioral therapy if they're open to this, because this really helps us understand constipation and our thoughts and feelings around constipation. Some patients really don't want to leave their house because of how uncomfortable they may feel when they are constipated, or they're worried about when their next bowel movement may be. Where will they be? And so these interventions really focus on the cognition, our thoughts, as well as our behaviors, and work together for a targeted treatment therapy in that way. There's not medications involved, and you're working with a specialized psychologist, behavioral health specialist that is focused on cognitive behavioral therapy specifically for your GI tract. Similarly, gut hypnotherapy is as it sounds. You are actually hypnotized during these visits, or at least trying to get into that hypnotized, relaxed state. And that's really, again, to talk about more positive thoughts and feelings around your bowel movements. And this is really helping rewire the gut and the brain connection to not send those alarm signals that I'm having pain, I'm uncomfortable, I'm trending towards harder stool, I'm having difficulty evacuating. It's really helping to rewire those gut-brain connections. I really like this diagram because it helps us understand the gut and the brain connection. And so it talks about how there are stressors that our brain is filtering out all day long. Those stressors are not the cause of our GI symptoms. But the way we like to look at this is that stressors are actually a dial to our GI symptoms. So as our gut and brain are trying to rework and refocus on these stressors that are coming in and out, the nerves of the GI tract are really amping up, and it becomes more difficult to filter out these signals. That then can also contribute to the pain, discomfort, bloating, distension, all the other symptoms you may have around constipation. So while stress and anxiety are not a cause of your constipation, they may dial up the symptoms surrounding this. Treatment from a medication perspective. Again, your healthcare provider is the best person to talk to about this, but here are some general options for treatment of constipation. Just like we talked about dietary fiber intake, fiber supplements can be a great help for your constipation. And this is just a list of what I'm going to go through in a little bit more depth in the coming slides. Like I said, we talked about dietary fibers. Now, there's supplemental fibers that are soluble versus insoluble. And those are just different types of fiber and how they work in our gut, helping to bring in more water, help to nourish the lining of the colon, nourish the lining of our stool, help give us more water, and help form stool to help us evacuate easier. Similarly, insoluble fiber can give us stool more bulk, not in a way that's going to cause more pain or discomfort, but give the stool a bit more form, soften things up, and help the transit time through our GI tract. And now we have prescription medications, or now we have non-prescription medication options. These are options that are available over the counter, but we encourage you to discuss these with your healthcare provider before trying these. There are certain agents that help draw in water to the intestine to help transit time throughout the colon. These are osmotic agents. This will help and soften your stool if you have that dry, hard, lumpy stool, and this will allow for a more complete and comfortable evacuation. Stool softeners similarly can do something the same, where they add in water and help things become softer and easy to pass. They do work differently, Every medication works a little bit differently. Stimulant laxatives, or medications that help stimulate the GI tract, really work on muscles. So, as much as the prior two interventions help draw water into the colon, these help work on muscles and stimulating muscles to help facilitate motility, so that movement through our colon. And then there's agents that are used and placed rectally, like suppositories or enemas, that help evacuate stool that may be towards that bottom part of our colon that is just having difficulty to evacuate. So they similarly help soften stool and stimulate evacuation. I'm not going to spend a lot of time talking in depth about these options, but I did just want to mention that there are prescription medications for our constipation. Medications called secretagogues really help bind to a receptor in our gut, in our colon, that leads to an increase in water release throughout the colon to add more fluid in to help soften stool and help us evacuate. There's 3 different agents that fall in this category, and each have different approvals. Linaclotide, for example, is approved for chronic constipation, but also for IBS with constipation. Amitiza, for example, is also approved for chronic idiopathic constipation, IBS with constipation, and even opioid-induced constipation. Plecanatide is approved for treatment of chronic constipation, IBS with constipation. And these are things that we would, again, want you to discuss with your healthcare provider, because you may benefit from certain medications based on the symptoms that you've discussed. Again, here's an additional 3 medication options that you could discuss with your healthcare provider. Prucalopride is approved for chronic idiopathic constipation, again, working on binding to a receptor in your gut to help regulate and improve the motility, the squeeze, the ability to evacuate your stool. Tenapanor is approved for irritable bowel syndrome, IBS with constipation, and it actually decreases the colon's ability to let water leave. So it holds the water in to help you have a more softer formed stool to help you evacuate this. We didn't talk a lot about this, but there are actually treatment options specifically for opioid-induced constipation. Opioids, or pain medications, do have an increased risk of constipation, so we have developed treatment options to really target this for patients who need this particular therapy. Over the next couple slides, I'm just going to wrap up on what we've talked about today and when you should see your healthcare provider. We did allude to this a little bit throughout the presentation, but anytime constipation comes on suddenly, feels very new for you, lasts a longer period of time than just a few days, it would be good to talk to your healthcare provider about that, just to make sure you don't need additional testing. Blood in your stool, bright red blood, significant abdominal pain that's new or different, black stool, very black, very tarry stool, you should always discuss with your healthcare provider, especially when that's new in onset, just to make sure there's no additional workup that would be needed. We like to rule out bleeding in particular with those instances. Severe bloating, nausea, vomiting, again, these things that are different and out of the ordinary for you, I would definitely review with your healthcare provider. Any new onset of rectal pain, laboratory testing that shows your blood counts are low, or anemia, that should be reviewed with your healthcare provider. Complete new onset of symptoms, particularly as we age, that's not a trajectory we always see, so we do like you to discuss this with your healthcare provider. Like I said before, losing weight without trying. We always want to know if it feels like weight loss is disproportionate to exercise you're doing or ways that you're trying to lose weight. And we also like to take into account your family history. In particular, when we're thinking about your bowel movements, your family history around inflammatory bowel disease or colon cancer. Again, this is not an inclusive list, but just things that we think about that we want to hear as healthcare providers. And to wrap up, we always want you to discuss any symptoms that you're having, especially if they're new or different, with your healthcare provider. The general takeaways, especially from a non-medication treatment perspective: stay active as best you can, hydrate as best you can, incorporate dietary fiber, and this will ideally help you have softer, easier to pass bowel movements. I also want to end by saying constipation is a very treatable condition. There's so many different options: medication, non-medication, physical therapies, gut hypnotherapies, that we can find to fit your needs the best. Thank you.
My name is Stephanie Owyang. I'm an instructor in medicine at Harvard Medical School, and I'm a gastroenterologist at Brigham and Women's Hospital. I'll be talking today about diarrhea. So diarrhea is defined as loose or watery stools reflecting increased water content. Some definitions also include frequency, so greater than 3 stools over 24 hours. The Bristol stool form scale on the right here shows basically the range of stools. This is a good way to talk to your provider about stool consistency. And so this ranges from type 1 to type 7. Type 1 and 2 reflect constipation. So these are hard, lumpy stools. They're hard to pass. Normal stools are typically type 3 or 4. These are more like a sausage. They're smooth. They may be smooth. They're softer. Type 5 can be normal or diarrhea. And type 7, 6, and sometimes 5 can be diarrhea. So these stools are mushy or watery and poorly formed. In the U.S., around 6 to 10% of people will have acute diarrhea in any given month, and around 6% of adults will have chronic diarrhea. So we can't talk about diarrhea without talking about fluid balance in the GI tract. The GI tract actually handles a really large amount of fluid throughout the day. Of this fluid, 2 liters is oral intake. The additional 7.5 liters is from secretions from the GI tract itself. The small intestine actually absorbs most of this fluid, so around 8 liters are absorbed by the small intestine and go back into the bloodstream and out into the urine. An additional 1.5 liters is left for the colon, and the colon typically absorbs around 1.3 liters, give or take, although it has absorptive capacity up to 3 liters. So overall, 0.2 liters or 200 mLs is left to be excreted in the stool. And so stools with water volume of greater than 200 mLs are considered mushier or diarrhea. And so how can we get increased fluid in the stool? We can have increased secretions in the intestines, whether that be the small intestine or even the colon. We can have decreased absorptive capacity in the small intestine or the colon. And so on the right here, we have a diagram of what normal fluid absorption in the GI tract should look like. So in the middle of the diagram, you see the lumen, so the inside of the intestines, and then on the sides, we have the walls. And so you can see the arrows pointing outward, indicating that fluid is being absorbed out of the lumen into the bloodstream or the body. So like I mentioned, fluid absorption typically occurs in the small intestine, as well as the colon. And diarrhea occurs when absorption of this fluid is impaired or secretion of fluid is increased in the intestines. And so the most common form of diarrhea is osmotic diarrhea. This worsens after food and improves with fasting. And this is due to increased solutes in the lumen or osmotic agents. And so what happens is we have things in the lumen that cannot be absorbed, and they draw water into the lumen or the inside of the gut. So we have excess water in the inside of the gut that can't be absorbed. We also have osmotic agents or solutes that can be fermented by bacteria, causing gas. And so some common forms of osmotic diarrhea include malabsorption, so lactose intolerance is a big one. We also think about dietary factors, so artificial sweeteners that cannot be absorbed, so sorbitol, for example. Osmotic laxatives, so polyethylene glycol or Miralax, and magnesium, so things that are typically used for colonoscopy preps or the treatment of constipation work this way. Other factors like bile acid diarrhea, so in patients who've had a cholecystectomy, have had their gallbladder out, or patients who have had part of their small intestine out so they can't reabsorb bile acids. Another common cause is medications, so for example, metformin can actually increase bile acids and also cause a diarrhea. Another cause is decreased small intestinal surface area or injury to the small intestine, so that can cause malabsorption. So there's a lot of things that can cause that, amongst them inflammatory bowel disease, post-infectious diarrhea can even cause this, and celiac disease. So secretory diarrhea is another form of diarrhea that's pretty common. This consists of large volume watery diarrhea that tends to persist despite fasting. So an example of this might be a patient who will have diarrhea in the middle of the night. They'll have to wake up to have diarrhea. This occurs due to active secretion of electrolytes or impaired absorption of electrolytes. So there are excess electrolytes in the lumen or the inside of the gut, and this also draws water in. Water will follow electrolytes, so there's excess water on the inside of the gut. Typically, these are infectious sorts of causes. We've all heard of cholera, for example. Other causes like norovirus and other viruses. Parasites in populations who are at risk for these infections. Other causes include bile acid diarrhea, microscopic colitis, so microscopic inflammation in the colon can cause a secretory diarrhea, and very, very rarely hormonal tumors. Disordered motility is another cause of diarrhea, so this typically is more frequent, smaller volume stools. It can improve with fasting and also can be intermittent. And so what happens here is that actually the colon moves faster, or the intestines move faster. So we see faster transit. And with faster transit, there's actually less time to absorb fluid. So you can see that the arrows showing fluid absorption are smaller in this diagram. Common causes of this includes IBS, so irritable bowel syndrome, neuropathies, so patients with diabetes, for example, might have damage to the nerves of the gut that causes it to move in an irregular way, hyperthyroidism or other hormonal conditions, medications, so antidepressants like SSRIs, for example, metformin can cause this, or certain antibiotics, and also bile acids. Inflammatory diarrhea typically presents as frequent small volume stools with pain or urgency, and oftentimes associated blood and mucus. Patients may also experience weight loss and fatigue, as well as fever if it's been going on for a long time or if it's particularly severe. This occurs due to disruption of the epithelial barrier function. So by that I mean that the lining of the intestine actually becomes damaged and maybe a little bit leaky. And so we actually see a lot of the different mechanisms that we talked about on the previous slides here, where we have impaired absorption of fluids, impaired electrolyte gradient, and also loss of proteins even, and poor absorption of osmotic agents. And so we can get diarrhea through all of these mechanisms in inflammatory diarrhea. And so there are some invasive infections, particularly bacterial, that will actually invade the lining of the intestines that can cause this. And then inflammatory bowel disease. So not infectious, but kind of chronic inflammation can cause an inflammatory diarrhea. And overflow diarrhea is an important one to mention. It's not true diarrhea in the sense that this often happens to patients who have a history of constipation. And so patients will actually have diarrhea, sometimes alternating with constipation. And this occurs because there is solid stool impaction in the distal colon or the rectum, which leads to rectal distension and then overflow of liquid stool around that rectal stool ball. And this can actually result in fecal incontinence. So around 14% of constipated adults will actually experience incontinence. In terms of duration, diarrhea can be classified into acute, persistent, or chronic. And so acute is typically self-limited. It lasts 2 weeks or less. We usually think of acute diarrhea as infectious for the most part. So viral illnesses can cause this, bacterial, like food poisoning, traveler's diarrhea, and certain medications as well. Persistent is 2 to 4 weeks. So things that can cause persistent diarrhea include infections that kind of persist despite treatment or aren't treated, post-infectious IBS, so the development of irritable bowel syndrome after an infection, early IBD as well, or early chronic inflammatory conditions can cause persistent diarrhea, and then medications as always. Chronic diarrhea lasts 4 weeks or more and can be classified into irritable bowel syndrome with diarrhea. We also think about inflammatory conditions like inflammatory bowel disease or microscopic colitis. Also dietary issues like lactose intolerance, celiac disease is included here, surgeries, and medications, of course. So you can see medications are on all of these. And so it's really important to talk to your doctor about what medications you're on and whether these could be causing diarrhea or not. And then of note, chronic diarrhea is very rarely infectious. This is a framework for discussing your symptoms with your physician. And so they may ask questions around onset or frequency or timing, but This is really just a list of questions that might be asked and things to think about prior to seeing someone in clinic, for example. And here I've really just highlighted in red certain symptoms that might be cause for a little bit more attention or further workup. And so those would be chronic diarrhea, so diarrhea that's been ongoing for more than 4 weeks. If it wakes you up from sleep at night, if you have blood in your stool, if you're having fever or weight loss or other kind of constitutional sort of symptoms, if you've traveled or had any recent antibiotics, and then of course if you have known GI conditions, if you're immunosuppressed for whatever reason. It's not by no means exhaustive, but this is just a list of different tests that may be ordered to evaluate diarrhea. So blood tests, so including basic labs, looking at blood counts or electrolytes, celiac serologies to screen for celiac disease, thyroid testing, looking for inflammation in the blood. Stool studies that might be ordered include infectious studies. So, for example, looking for bacteria or viruses or even parasites. Fecal calprotectin is a test that can be ordered to look for inflammation in the stool or inflammatory markers in the stool. And then other endoscopic tests such as colonoscopy, upper endoscopy, even breath tests could also be considered, just depending on what symptoms you're having. So this is just categorizing all the different treatments for diarrhea. And of course, these will also vary depending on your symptoms. And so the first line is oftentimes dietary modification. So avoiding things like lactose or artificial sweeteners, coffee, spicy foods, etc. And then oral rehydration I'll talk about on the coming slides. Anti-motility agents like Imodium or loperamide are medications that actually slow the transit in the intestines and so increase the time for fluid absorption. Anti-secretory agents, so Pepto-Bismol, for example, really just reduce the fluid losses into the intestine. Antibiotics if there is a bacterial infection, and then bile acid sequestrants if there's concern for bile acid diarrhea. And so with diarrhea, it's obviously very important to maintain hydration. So signs of dehydration might include dry mouth, if you're super thirsty, reduced urine output or darkened urine, lightheadedness. And typically when people are having mild symptoms or mild diarrhea, usually they can get by just drinking water, juice, sports drinks, saltier soups or broths and saltines. But really, if you're having moderate or severe or large volume diarrhea, or if a patient is elderly or a bit frail, then really thinking about oral rehydration solutions. So I'll have a slide on that. But an example of an oral rehydration solution is Pedialyte. And then if you really aren't able to maintain hydration with oral fluids, then consider going to the hospital, of course. And so just a quick note on oral rehydration solutions as compared with sports drinks. So actually, sports drinks are designed for exercise, so losing fluid through sweating. And oral rehydration solutions are really designed for GI losses, so losing fluid through diarrhea or vomiting. And so the difference here is actually that sports drinks contain a higher sugar content, whereas oral rehydration solutions contain more electrolytes like sodium and potassium rather than a lot of sugar. And the way oral rehydration solutions work is they actually take advantage of this thing called the sodium glucose cotransport, which is often intact when you have a secretory diarrheal illness. And so really the way this works is sodium and glucose are absorbed, and that actually facilitates the absorption of water. And so the WHO actually has guidance on oral rehydration solutions, namely what the important components or ratios of the oral rehydration solution are. And so there are also some home recipes that can be followed, but it's really, really important to also make sure that you're looking at the ratio of each ingredient using these recipes. And so just to summarize, diarrhea is defined as loose or watery bowel movements, typically more than 3 bowel movements every 24 hours. The diarrhea is due to basically increased water content in the stool, so increased secretion of fluid or impaired absorption of fluid in the GI tract. We discussed causes of diarrhea. We discussed the classification of acute versus chronic, in which acute is usually infectious and chronic less so. We talked about certain symptoms that might prompt further workup or closer attention. We talked about different ways to hydrate depending on symptom severity. And then we also discussed treatments. That concludes our presentation on diarrhea. Thank you so much for your attention.
Thank you so much, everyone. My name is Vikram Rangan. I'm one of the GI doctors at Beth Israel Hospital, and I work in our GI motility unit there and see a lot of patients with irritable bowel syndrome and other bowel function abnormalities. And so I'm very happy to be here today talking about changes in stool and appearance. Questions about stool appearance are very common in our clinics. Patients will always ask, is such and such change in stool normal? Is such and such change in stool a cause for concern? And so, given how common these questions are, I think it's a very important topic for us to discuss. So, during this talk, I'll be talking about various different changes in stool appearance and form that can be a cause for concern. But I think the big picture point that I'll be coming back to again and again during this presentation is that the vast majority of stool changes that patients see are completely normal and are not a cause for concern. There's a very wide variety of factors that play into how stools look, whether it be diet, gut bacteria, how active you've been on a certain day, how much water you've drank on a certain day, medications, environment, etc. And given these wide variety of factors that impact stool appearance, the majority of changes in stool appearance are just going to be normal day-to-day fluctuations and not a cause for concern. So I'll try and bring that point home again and again during this talk. As we mentioned, there's a wide variety of stool color, consistency, texture, and frequency that's considered normal. And, stool appearance is one of those things where if you ask 10 people what a normal stool is, you'll get 10 different answers. Factors that can impact stool appearance include diet, gut bacteria, medications. Um, as we all know, normal stools are brown colored, and that brown color is a result of a substance called bile that the liver makes that helps the body to break down fat. But even within this umbrella of brown colored stool, there's a whole wide variety of different appearances that patients will note. So we typically say that the normal bowel frequency ranges from one bowel movement every 3 days to three bowel movements in one day. And within that frequency range, we also see a lot of different stool consistencies. And a lot of times it's tough for patients to give a clear cut description of what the stool looks like or how consistent it is. And so this Bristol stool chart is a tool that we oftentimes use just to standardize description of what stool looks like. And so when patients tend to be on the more constipated side, the stools tend to look more like this type 1 and type 2 stool, this ball-like harder stool. And when patients move more to the diarrhea side, stools tend to be this looser type of consistency. Typically, we'll say that quote unquote normal bowel movements range from this type 3 to type 5, where there are these more formed so called sausage shaped stools. But with that said, even if stools range a little bit into the constipated or diarrhea or Bristol type 1 or 2 or Bristol type 6 or 7 side of things, it's not necessarily a cause for concern and something that immediately needs to be treated. In the majority of cases, what we really go by is how the patient is feeling. As we said, some patients can have three bowel movements a week and feel completely normal. If that's how the patient feels, that's completely fine and there's no treatment that's needed. Other patients may have three bowel movements a week and feel really backed up, get really bloated and distended in between bowel movements. And in that case, we may want to treat a little bit more aggressively with a laxative medication. But again, just driving home the point that how the stool looks, we don't really need to make any definite, a lot of times we don't, that shouldn't be the only thing that guides our management. Just because there's such a wide range of normal, we have to put things together with how the stool looks and how the patient feels in order to decide if there's truly something that needs to be done or not. So there are many changes in stool appearance that patients will frequently describe that are not really thought of as a cause for concern. For example, patients will note dark stool, sometimes they'll note food particles mixed in the stool, sometimes they'll note mucus in the stool. They can note stools that are floating at the top of the toilet bowl. They can mention stools that come on very soon after eating. None of these are really thought of as a cause for concern or a sign that anything is wrong. The colon naturally produces mucus, and so the presence of mucus in stool is not necessarily a cause for concern. And it's very common to have what we call the gastrocolic reflex, where soon after eating, the entire gut becomes more active and tends to push out a bowel movement. So the presence of bowel movement soon after eating is also not a cause for concern and doesn't necessarily mean that the stools are going right through you, which is the way that many patients feel. And the same way, dark stools or food particles mixed in stool, not any immediate cause for concern. And in many cases, it's simply a result of what you're eating and how it interacts with the gut bacteria. There are a wide variety of foods, rather, that can impact stool color. So, examples, this is not an exhaustive list, by the way, but common examples include green vegetables, beets, blueberries, cherries, black licorice, pistachios, carrots, food dyes. Beets are known to give reddish colored stools that can be confused with blood in stool. Foods like blueberries, licorice, and green vegetables have a tendency to give darker stools as well. But again, these changes in stool color associated with these certain foods are not typically thought of as a cause for concern. Medications can also significantly impact stool appearance. Again, this is not an exhaustive list, and there are many medications that can have an impact on how the stools look. It's very common for patients to notice dark stools, almost black stools with iron supplementation or with Pepto-Bismol. And then antibiotics will oftentimes impact stool appearance as well. We've talked a lot about normal stool appearance and kind of non concerning changes in stool appearance. So we'll kind of segue now to talking about changes in stool appearance that can potentially be a cause for concern. But again, before jumping in, I'll just mention that these potentially concerning changes in stool that I'm about to mention are generally the minority of cases that we see in clinic. The vast majority of stool changes that patients ask about are one of the benign changes that we talked about before that are probably just a result of food intake or some other environmental or other non-concerning factor that's impacting stool appearance. So, in terms of changes in stool that can potentially be a cause for concern, on this top left panel here is what looks like clay-colored stool. That's a lot lighter colored appearing than the normal brown stool. In the middle here, you're seeing black tarry bowel movements that have neither this nice stool form and also appear jet black or tarry black. Um, the presence of blood in stool, that's a finding that oftentimes can be suggestive of something wrong. Um, and then this stool appearance here on the lower right, um, basically loose stools with oil floating on the top of the toilet bowl. That's a finding of what we call steatorrhea, and that can be a finding suggestive of fat malabsorption. Um, and so we'll talk a little bit more in just a second about all of these very specific changes in stool appearance. But these are the types of changes that would suggest a need to talk to a doctor more. And then change in stool caliber is also another change that potentially is a reason to seek attention. The main reason for this is that if there is some sort of mass lesion or cancer near the end of the colon in the rectum, that can result in thin or so-called pencil type stools. And so if there's this very specific change in bowel function with consistent pencil type stools, that would be another reason to seek medical care. But again, I would just emphasize that thinner stools happening every now and then is usually not a cause for concern. Usually there has to be this consistent change in stool appearance. I would also mention that a lot of patients have what we call pelvic floor dysfunction, where the pelvic floor muscles don't coordinate properly to get stools out. This is a benign condition, but that can also lead to thinner stools. And so, especially if thinner stools are happening only on an intermittent basis, most likely they're not a cause for concern. But I would just mention that these thinner pencil-type stools occurring on a consistent basis, that would be a reason to seek medical care. So just a little more details on some of the specific changes in stool that we talked about on this last slide. So I'll start by talking about melena, which is this black tarry stool that you see in this middle panel here. So when we see this black tarry stool, that can be suggestive of bleeding from the GI tract, specifically bleeding from the upper GI tract, like the stomach or the first part of the small intestine. And so if there is this appearance of black tarry stool, especially if it occurs in the setting of the patient feeling lightheaded, dizzy, short of breath, or having chest pain, that would be one concerning finding that would suggest that there could be an ongoing GI bleed, and that would be a reason to seek medical care. So that's certainly something to be aware of, and that's one change in stool that shouldn't be downplayed. The presence of blood in stool, that's also a finding that's never normal, quote unquote, although in the majority of cases, blood in stool is just a result of hemorrhoids, which are enlarged veins right near the end of the colon, and a completely benign finding. But with that said, blood in stool can be a result of many more concerning findings as well, including cancer, inflammation of the colon, such as Crohn's disease or ulcerative colitis, some sort of infection of the colon or small intestine, or what we call a bleeding diverticulosis. So these pictures below give a couple of examples. So this picture on the left here is a large colon polyp. Those large polyps can sometimes bleed on their own, or over time they can turn into cancers, which can result in bright red blood from below. This middle picture is a picture of colonic inflammation. This was a patient who has bad ulcerative colitis, and that can lead to active rectal bleeding. And then this picture on the right here is, you can see these small little potholes in the colon. Those are what we call diverticulosis. And in the majority of cases, diverticulosis doesn't cause any problems, but it does have the potential to cause bleeding. These are all potential causes of bleeding from below. And I would say that anytime there is blood from below that doesn't have a clear explanation, that probably is a reason to seek medical care. I would say that in the majority of cases, it will turn out to be something benign like a hemorrhoidal bleed. But anytime a patient sees blood in the stool, there should be testing done to make sure it's not one of these more concerning causes, and to make sure that the patient isn't losing a large volume of blood. So similar to the black tarry stool that we mentioned above, I would say blood in the stool, especially if it comes with dizziness, lightheadedness, shortness of breath, would be a reason to seek medical care. If a patient already has undergone a colonoscopy or other testing, and if it's felt that the cause for bright red blood from below is known, then it may not necessarily be concerning if bright red blood were to recur. Like hemorrhoidal bleeding is known to happen on an on and off basis. But if this is happening for the first time, I think there should be a discussion with a medical professional just to see what testing is indicated. So clay-colored stools, where stool lacks the normal brown color and looks very light-colored, that can be a sign of the bile ducts being blocked. Like we talked about at the beginning, the normal brown color in stool is a result of this substance called bile that helps the body break down fat. Bile is produced by the liver, and it then gets secreted through these ducts into the intestines, where it helps to break down fat. If there's a blockage of these bile ducts, which usually happens if the patient has a gallstone or some sort of mass lesion that's pushing on the bile ducts, that can lead to these clay-colored stools. And that would be a potentially concerning finding that may indicate a need for some sort of imaging to get a better sense of what's going on. And then this steatorrhea, or basically loose stools with oil droplets floating in the toilet bowl, that could be another reason to seek medical care. If indeed the patient does have fat malabsorption, which can result if there's a problem with the pancreas producing enzymes to break down fat, or if there's a problem with the intestines not absorbing fat properly, stool can have this appearance with loose consistency and oil droplets in the toilet bowl. There again, that's something that would not be thought of as a normal thing to be seeing on a regular day-to-day basis, and that would be a reason to seek medical care, just to think about whether further testing for fat malabsorption or maldigestion is needed. So, we've talked about several changes in stool that could potentially be a cause for concern. Black tarry stools, blood in stools, pencil thin stools, light colored stools, and stool that has the appearance of oil droplets or fat in the stool. All of those are potential reasons to seek medical care or at least speak further with a primary care doctor or gastroenterologist to see if further testing is needed. But again, to conclude, I'd like to bring it back to the original point, which is that there are a wide variety of factors that play a role in stool appearance, and the vast majority of changes in stool are normal and simply a result of day-to-day factors like dietary change, water intake, medicines, exercise, etc. And the majority of stool changes are not a cause for concern, largely because there's just such a wide variety of normal stool, and it's very tough to define what exactly is quote-unquote normal, since every person's normal is different. But with that said, there are a couple of specific changes in stool that could be a sign of a more concerning process, and being vigilant for those is something that we would recommend, and having a low threshold to speak to a medical professional if any of those changes are noted. Thank you all very much.
Hello, my name is Alex Goldowsky, member of the Division of Gastroenterology, Hepatology, and Nutrition at Beth Israel Deaconess Medical Center, and director of the Center for LGBTQIA+ Digestive Health at Beth Israel Deaconess Medical Center. And I'm here to talk to you about why you might be running to the bathroom, fecal urgency, and the gastrocolic reflex. These are my disclosures. For our learning objectives today, we're going to talk about the gastrocolic reflex and explain when fecal urgency is normal and abnormal. We'll discuss common causes of fecal urgency, describe how to speak to your doctor about fecal urgency, and discuss what a doctor may recommend for testing and treatment. So, here's a common story I hear all the time. You're sitting down at your favorite restaurant with a couple of friends and have just ordered your favorite dish, a cheeseburger with all the fixings. You take a few bites and are enjoying great conversation and laughs, when all of a sudden, something doesn't feel right. Next thing you know, it feels like your lower belly is in knots and you're running to the bathroom. Thankfully, a stall is open and you're able to make it in time. But you think to yourself, darn, this is the third time this has happened to me in the past 2 weeks. What is going on? As a gastroenterologist, I've heard this story countless times. This is fecal urgency, and it can be incredibly alarming and really decrease a person's quality of life. I'm here to explain to you why this might be happening, what is normal and what is not normal. But before we start, a science lesson is in order. The science lesson is about the gastrocolic reflex, and this is a normal reflex in all of us. Whenever you eat food and it hits your stomach, the stomach gets stretched. This causes nerves and hormones to signal to the brain that we need to start moving things along in the GI tract. This then causes the intestines and the colon to squeeze, which can lead some people to have a bowel movement after they eat. Now, the questions are, why is this important? And why do some people have fecal urgency and others do not? If you think about it, without this reflex, we would just keep filling up without a pop-off valve to let things out. So it allows room for us to eat more food. It allows the body to help move stool forward in a more efficient manner. The way that this is done is via something called the migrating motor complex, and these are big contractions of the intestines and colon that occur less frequently throughout the day and night. Now, there are many different nerve pathways and hormones involved. It doesn't take much for things to go awry in some people, which can lead to symptoms like fecal urgency. Between meals, there are smaller movements of the intestines and colon called peristalsis. These are finer movements, but do not propel food and stool forward as efficiently as those bigger migrating motor complexes. Now, when it comes to the question of why fecal urgency strikes some people, but not others, this is even more complex. There isn't just one reason why this can happen. It's the confluence of many different things, including not just the food we eat, but also medications, the environment we live in, the healthy bacteria in our intestines called the microbiome, stress, and more. This is what we call the microbiome gut-brain axis. And this can help us to think about why fecal urgency occurs in some, but not all people. Now that we have a better idea of the science behind fecal urgency, let's talk about what features make fecal urgency abnormal. Remember, needing to use the bathroom after eating is not necessarily abnormal. However, there are certain symptoms that definitely require a visit to the doctor to discuss. These include the following. Diarrhea. Now, diarrhea for gastroenterologists means having more than 3 bowel movements in a 24-hour period. Blood in the stool is never normal and should always be evaluated. Accidents, otherwise known as fecal incontinence. Significant belly pain. Waking up in the middle of the night to have a bowel movement. Weight loss that wasn't intended. And finally, anything that's interfering with your quality of life. We recognize that quality of life is very important to everyone. Whenever a symptom is interfering with that, we take this very seriously, since we never want our patients to feel so unwell that they cannot live a life that they are happy with. Now, there are many common causes of fecal urgency, and I'd like to talk about a few of them. Irritable bowel syndrome. This is a diagnosis that many people are given, but actually has pretty strict criteria. I'm not going to go into what those criteria are, but know that this is one of those disorders that affects the microbiome gut-brain axis and is quite common. We do not have a test for this, but we do want to make sure that we aren't missing a different, potentially more serious and treatable problem. Diet-related fecal urgency, another very common cause. Common foods that can trigger fecal urgency include caffeine, so coffee and chocolate, spicy foods, fatty and fried foods, and dairy. But everybody is different and can have their own specific triggers. Whenever you have a GI bug, that can definitely lead to fecal urgency and having you run to the bathroom. Constipation. Now, this may sound counterintuitive, but when people get very constipated, stool still needs to find a way to get out. The easiest way for it to do so is by staying liquid and leaking around the hard stool in the colon. This can lead to urgency. Inflammatory bowel disease, which includes Crohn's disease and ulcerative colitis, is a much rarer cause of fecal urgency, as are diabetes and nerve problems. But your doctor may end up doing tests to make sure you don't have one of these problems. Now, I want you to notice that cancer is not on the list of common causes. Fecal urgency being the only symptom is rare in colorectal cancer. Again, your doctor may end up doing tests to make sure you don't have cancer, but this is unlikely in the absence of other more alarming symptoms. Now, we understand that talking about bowel movements can feel uncomfortable and sometimes embarrassing. Just know, we talk about it all the time, and we've heard it all. It can be helpful to come prepared to your doctor's visit, so here are some questions you're likely to be asked. How long has the urgency been occurring? Is it just for a few days, or has it been longer? How many bowel movements do you have per day? Are there certain foods that trigger your symptoms? Are there any other triggers for your symptoms, like stressful periods potentially? What does your stool look like? Is there blood in it? Is it a different color that you're not used to? Do you wake up in the night to have a bowel movement? And have you tried any over-the-counter remedies or been prescribed medication in the past for urgency by your primary care doctor? Doctors may also ask you about your travel history, your sexual history, or if someone has been sick around you. Now, I am not a spokesperson for any of these apps, but there are many for both Apple and Android products that allow you not just the ability to track your bowel movements, but also the food that you are eating and other symptoms you might be having. This can help keep tabs on a lot of information and may even be able to help you identify triggers and may be helpful for you to bring up to your doctor. Now, your doctor may order different tests to help try to figure out a reason why you're having fecal urgency. Blood tests can check for things like thyroid disease, celiac disease, which is a gluten allergy, as well as signs of inflammation. Stool tests can check for infections, inflammation, and other less common causes of fecal urgency, like pancreas problems. Imaging, like an X-ray or a CAT scan, can look for inflammation or other structural causes that might lead to fecal urgency. And then a colonoscopy is a test where a camera is inserted into the colon via the anus and rectum so that the inside can be seen. One of the benefits of a colonoscopy is that we can see if there is inflammation and also take biopsies, little pieces of colon tissue, to look under the microscope. Now, I know you're all probably asking yourselves, I understand this, but what are some ways that we can manage fecal urgency so I can feel better? Avoiding trigger foods can sometimes be the easiest way to improve fecal urgency. In general, these foods are not dangerous for you, but they might be inconvenient. It can help with decision-making when you're going out to eat or with friends or family. Fiber can help bulk the stool. Especially if stool is not in a normal form, a fiber supplement can really help with getting it closer to normal. This can help with urgency, as more liquid stool is more likely to lead to urgency. Sometimes, a doctor can prescribe medication that prevents spasm or muscle contraction in the colon. These are called antispasmodics or antispasm medications, and tend to work on the quicker side. They can also be used as needed, so they're a nice option for around meal times, which can be a common time for urgency to occur. Taking them 20 to 30 minutes prior can be a big help for some people. Finally, there are medications that really slow down the GI tract. Medications like loperamide or Imodium can slow down the GI tract and make it less likely you'll experience fecal urgency. However, you need to be careful, as sometimes these medications work a little bit too well and can lead to constipation, which also makes people feel unwell. Use this in emergencies or during times where you absolutely cannot be having a bowel movement, such as during travel. Some take-home points: the gastrocolic reflex is a normal way for the body to move food and stool forward in the GI tract. Fecal urgency is complex and can occur for any number of different reasons. Common causes of fecal urgency include irritable bowel syndrome and diet-related urgency. Come prepared to your doctor's office visit, and it can really help to narrow why fecal urgency is occurring. And there are different testing and treatment options available in the hopes that we can improve symptoms and quality of life. Thank you very much.
Hi, I'm Dr. Ramprasad. I'm on faculty at Beth Israel Deaconess Hospital. Today we are discussing fecal incontinence. I have a couple take-home messages that I want to make sure you leave this talk knowing. The first is that fecal incontinence is common, but it's treatable. Don't suffer in silence. Talk to your doctor. It's embarrassing at times to discuss many GI topics, but this in particular can be a challenge. Lifestyle changes and physical therapy can make a large difference and can really help a lot of my patients. And lastly, support is available, both medical and emotional. As a background, fecal incontinence is defined as involuntary leakage of stool. That's either solid or liquid stool. It can range from occasional leakage to complete loss of bowel control. It affects, unfortunately, patients of all ages, but more common in older adults, and we think it's more common in women compared to men. About 1 in 12 adults will suffer from fecal incontinence. Although we say that older people will suffer from it more, it's not necessarily a normal part of aging. Just because someone's getting older doesn't mean that they should have to suffer from fecal incontinence. And lastly, it's often underreported because people are embarrassed. It's not something you really want to talk about. Most of my patients will hesitate a little bit before they bring this up to me. If they came into my clinic with a family member or a friend, they may even ask that family member or friend to leave the room before they sit down and really tell me what's going on. So whatever makes the patient more comfortable, whatever makes you more comfortable to discuss this, it's important to be open and forward with your doctor. I want to start with a case. We have a 68-year-old female retired teacher, healthy, but began noticing small leaks of stool when rushing to the bathroom. She was embarrassed, and it's been bothersome enough where she started to avoid social events, which she really liked going to before. We did an abdominal x-ray, which demonstrated large amounts of stool burden. And yes, this patient did corroborate this with years of worsening constipation. As a treatment, we really focused on managing the long-term constipation. And specifically here, we did fiber supplementation, magnesium oxide, exercise, and an increased diet of fruits. And so big picture here, we're trying to manage the constipation symptoms by helping to have more effective, more complete bowel movements. And you may ask, what kind of fiber? I hear about all sorts of fiber on TV. I have all these advertisements. People talk about fiber all the time. The best type of fiber is the one that you like taking. I have patients who tell me they like Metamucil. They like to take chia seeds or flax seeds or increased fruits. The best fiber is the one that you enjoy taking, the one that you will regularly take. So some of my patients who are more towards natural remedies may focus a little bit more on food supplementation. Others may do fiber that is psyllium or Metamucil, and for them that works great. Secondly is magnesium oxide. And you might ask me, why not Miralax? I've heard a lot about polyethylene glycol, and that's a way that people manage their constipation. I think that's great. That works for a lot of people. Magnesium oxide is something that I use in my clinic, again, because people like a little bit more natural types of treatment. Magnesium oxide comes in small pills. It actually also helps with sleep and muscle fatigue. And all these together, taken nightly, can be very effective for people for management as an osmotic laxative or something that brings in water to the colon to help with bowel movements. Next is exercise regimen. I think this is very important. I have a lot of patients who feel better after engaging their core, using weight training, and a lot of my patients are trying to manage osteoporosis or weak bones, and they use exercise with weight training to help their bones, and I describe it in a similar way. We have to engage the core, have good bowel movements after exercise, so this is very important. Lastly, exercise with increased diet of fruits. Fruits are very important sources of fiber, and along with other fiber supplementation, fruits could be very helpful. So after my patient incorporated some of these into her daily routine, reported much more improvement, more complete bowel movements, and less frequent episodes of incontinence. There are many causes of fecal incontinence. We were just going through something called constipation with overflow. And I have some patients who ask me, how can I have constipation? I'm having bowel movements all the time. I'm having urgency. What I describe is exactly what just happened. There was a patient who had a backflow of stool. The only thing that could make it out was some small amounts of liquid stool. And so when you put in that context, constipation with overflow is actually a very common cause of fecal incontinence. There's also diarrhea or loose stools that is not from a backup of stool, with a lot of different causes there. There's also muscle or nerve damage after surgery, childbirth, after a stroke. There's aging-related weakening of the pelvic floor and conditions like diabetes or spinal cord injuries. So next we'll discuss Case 2, we have a 75-year-old female, retired nurse, healthy, but has episodes of fecal incontinence almost every week without any warning. An abdominal x-ray for this patient demonstrates small amounts of stool in the colon, so not a large amount. There is an anal rectal manometry that demonstrates weak anal sphincter squeeze with noted dysenergic defecation. And you may ask, what is an anal rectal manometry study? This is a study that measures the pelvic floor function, its ability to coordinate, to push, to have a coordinated bowel movement. And this is very much testing the ability of the pelvic floor to function in the way that it should. An anal rectal manometry for us in our hospital at Beth Israel Deaconess is with our nurses who are truly professional. They make it a comfortable experience. It is something that the vast majority of my patients say, I didn't think this was something that I'd be comfortable with, but the nurses were professional and I felt comfortable with doing it. And for this patient in particular, demonstrating that the anal sphincter squeeze was weak and there was not good pelvic floor coordination. So that term, as a medical terminology, is dysenergic defecation. We treated this patient with improvement in pelvic floor function with biofeedback pelvic floor therapy. So you may have heard about physical therapy for someone who has injured their shoulder, their knee. Maybe they need speech therapy because of changes in their throat muscles. I describe this as a very similar thing, but for the pelvic floor. This is an ability to retrain, coordinate the muscles of the pelvic floor to improve that overall coordination. So that's one treatment option. As I mentioned early on, I like to focus on lifestyle and diet. Some people may mention to me that every time they drink a large amount of coffee that has a lot of sugar with caffeine and other fatty foods, that's a real trigger for them. So we focus on trying to avoid the triggers. I say to my patients all the time, you have to be human. You have to like eating food. You have to like being social. But maybe you have a little bit less of that trigger food. Maybe you cut it out for a couple weeks and see improvement. But it doesn't mean you can never have an iced coffee again. Maybe the quantity and how you exactly make that iced coffee is different than it would be before when you're having a lot of symptoms. We've talked about increased fiber for better stool consistency. And hydration is very important because we want to have good, effective bowel movements. And if you're dehydrated, that makes it harder. Medical treatments are there. There's a lot of medical types of treatments, pharmaceutical, that could be helpful. For me, an anti-diarrhea medicine like loperamide is really a last resort. I would like to focus on the natural bowel movement, the natural cycle of having bowel movements and having evacuation and having your pelvic floor understand the triggers and the responses to the stimuli. So I think of an anti-diarrheal medicine like loperamide as a last resort, but it's there. Laxatives are always a part of constipation management. Some people will manage just with diet, but if you need to take a magnesium oxide or a Linzess, it's okay to take that if your constipation management requires it. We discussed pelvic floor therapy, and I really recommend that this is with a trained physical therapist who specializes in pelvic floor therapy, specifically with biofeedback. A lot in the media written about Kegel exercises and strengthening the pelvic floor, and that's great, but we really want it to be with a professional who knows exactly what your beginning level is, how you've improved, and what your success is with their treatment strategy. Therapists beyond physical therapy, but to discuss the psychological burden, very important. I started out by discussing how embarrassing and difficult this is to talk about. In the grand scheme of what we deal with in gastroenterology and gut health, fecal incontinence is really on the most burdensome psychologically that you could really consider. So I stress to my patients that they should have a therapist. They should have someone they can talk to about these challenges. I mentioned here an advanced option, which is nerve stimulation. This is invasive. I think of it as a very last resort. There's a lot of good data for the things that we've already discussed, but if there is a true need, there is possibly a role for sacral nerve stimulation. Our last case here, case 3, is a 61-year-old male. He's a retired physician. He has fecal urgency with incontinence every other week on average. His abdominal x-ray demonstrates moderate amount of stool in the colon, and we test him for small intestinal bacterial overgrowth. That's referred to as SIBO, and that test was positive. We treated our patient with SIBO, 2-week course of rifaximin. Rifaximin is a name of an antibiotic that treats SIBO. And SIBO, as I've described here, is an imbalance of the microbiome in our small intestine. And we're supposed to have a lot of good bacteria in our small intestine. That's what helps us digest. It's our genetic material in many senses. When there's an imbalance in that bacteria, that is a result of SIBO, small intestine bacterial overgrowth. Many different ways to treat SIBO, but rifaximin, this antibiotic, is one of the hallmark treatments. So the patient read also about a low fermentation diet, which is a way to treat SIBO. And the patient reduced high fructose corn syrup, which is found in a lot of our American diet to sweeten our foods. And the patient also avoided some highly fermented foods like beans and legumes, which are really driving up SIBO symptoms in patients. And after that patient made those changes, gradually noted much less frequent bouts of fecal urgency with incontinence. I mention SIBO here, small intestine bacterial overgrowth, because it's just one example of a gastroenterological disease that can lead to fecal incontinence. So fecal incontinence itself is not a disease. There's many causes of what that is. There could be Crohn's, ulcerative colitis, irritable bowel syndrome with diarrhea, irritable bowel syndrome or IBS with constipation, or celiac disease, amongst many other processes that may lead to fecal incontinence. So important here that if you have fecal incontinence, you should really have a conversation with your doctor about why is this happening? Do I have a disease process underneath that's causing this? Is that why you're experiencing this symptom? And oftentimes treating the underlying cause, treating SIBO, treating Crohn's, or treating adequately ulcerative colitis or IBS may actually lead to improvements in fecal incontinence. So I mentioned that not all causes of fecal incontinence is from SIBO, but many different causes can lead to fecal incontinence and should be adequately treated. So I end here with the take-home messages that we started with. First, fecal incontinence is common. We talked about the age trend and how it's difficult to talk about, but it's treatable. We talked about all sorts of management, understanding the underlying disease, treating with medicines or with diet, or trying to know when you have to go to the bathroom before you leave your house. Number 2 is don't suffer in silence. So some patients will pull me aside. They'll ask if a family member can step outside. Feel comfortable. Speak to your doctor exactly about what's happening. Number 3 is lifestyle changes and physical therapy can make a huge difference. Oftentimes, that's my first way to treat fecal incontinence. And lastly, but very importantly, support is available. So you have your doctor who will help you, but there's also emotional support that you may need as well. Thank you for your time.
Hi, everyone, and thank you for joining. I'm Dr. Lawrence Borges. I'm the Chief of Gastroenterology at Mount Auburn Hospital in Cambridge, Massachusetts, and I'm excited to speak with you today. Today, I want to talk to you about something we all experience but rarely talk about, gas or flatulence. Now, you may be surprised to learn how common and how normal it really is. But when it becomes uncomfortable or embarrassing, it's worth understanding why we get it and potentially what we can do about it. So to start, let's talk about what is flatulence. Well, simply put, flatulence is the passing of gas through the digestive tract, through the rectum into the air. It's something every human does, typically 10 to 20 times a day. In fact, most people who think they have too much gas are actually within the normal range. The gas we release is mostly like the ambient air, so it includes large proportions of nitrogen and hydrogen. smaller proportions of carbon dioxide, and sometimes methane. And despite popular belief, the gas we pass is typically odorless. However, the odor, when it does occur, comes from trace sulfur compounds made up by bacteria in the gut. So where does this gas come from? Why do we have it? Well, one of the major drivers of gas is swallowed air, or aerophagia. And this can come from eating, particularly eating too quickly, drinking, particularly drinking carbonated beverages, or chewing gum. Another large source of gas is fermentation of undigested food by gut bacteria. And this is typically from complex carbohydrates like fibers and sugars. It mostly occurs in the colon, and it's a normal part of digestion. So how do we know, however, what's normal and what's excessive? Well, again, normal gas is passing gas 10 to 20 times per day, believe it or not. However, it can be excessive, and we sometimes define excessive as when it causes pain, bloating, a foul odor, and particularly when it's socially disruptive. Now, importantly, because this is a misconception people often have, the discomfort from gas is often due to sensitivity, but not actual to gas volume. And the lower image here is just showing an image from a physiologic study done a long time ago that demonstrated this. So people who feel gas sensation are not necessarily more full of gas, they're just more sensitive to it. So we've talked a little bit about where it comes from, why we get it. Let's talk about the common causes of excessive gas to know how we can, hopefully intervene. Well, the most common thing that we talk about with patients in the clinic is going to be gas-producing foods. And as you might expect, this includes the sort of usual suspects: beans, lentils, onions, cabbage, and dairy. Now, this is just an image, that may give some of us anxiety from the whole food shopping counter. But let me pull up a chart. This is from a physician reference called UpToDate.com. And this spells out nicely some of the foods that are commonly associated with gas and bloating. There are other ways we could get it as well. Again, we mentioned aerophagia before, so swallowed air from fast eating, carbonated drinks, chewing gum. Artificial sweeteners is a common category that people may overlook because we use them so commonly in foods like coffee, tea, etc. And then interestingly and importantly, normal day-to-day activities like airplane travel can produce changes in atmospheric pressure that cause you to feel and expel more gas. So if you're traveling and having that as an issue, it's not necessarily something to worry about. So let's talk about when you should be concerned, right? We know that everyone's going to have gas, and we know that for the most part, having gas is normal. But when should you be worried? Well, certainly if you're experiencing a lot of flatulence and you're having unintentional weight loss, if you notice blood in your stool or ongoing change in bowel habits, particularly like diarrhea, if you experience new or worsening abdominal pain or discomfort, or nighttime symptoms or fevers. These are the so-called red flag features that we would want people to think about and be aware of, and you may bring up to your doctor. What would happen then? So if you're noticing a red flag feature and you're having flatulence, it's possible that some tests may be considered. Those tests would include things like stool tests, specifically looking for fecal fat content, fecal elastase content, and also infectious stool tests like Giardia, for instance. Breath tests are also very popular now. These are tests designed to look for things like small intestinal bacterial overgrowth, as well as lactose intolerance. Blood tests may be utilized. In particular, we often think of celiac disease if somebody comes in with excessive flatulence and GI symptoms. And then possibly further down the line, your doctor may consider an endoscopy or a colonoscopy for further evaluation. And I would point out that this is more often to be considered if there are alarm features present. So now the part we've all been waiting for, right? What can you do? So you have gas. We recognize it can be normal, but it's bothering you. What can you do? Let's start off first with diet tips, because remember we said the big category we always talk about is the foods you're eating. Very important to try and keep a food and symptom diary. Now, this is a piece of advice that we hand out in the office a lot, and sometimes I see people's eyes glaze over. Yeah, doc, I'll try. But truly, it can be very important, because if you keep a diary of what's bothering you and giving you more gas, that result is going to be more relevant to you than something you've looked up on the internet. Then, with that information, you want to limit gas-producing foods and test your response. So you can then try a controlled trial of saying, well, I ate this food last week and I felt like I had more gas. Let me get rid of that and replace it with something else for the next 2 weeks. And you can use charts that you might find, like the one I showed earlier, to help determine what's good and what's not. Also consider a low FODMAP diet. So I imagine this is a diet that you've all heard of, seen, talked about. Stands for fermentable oligo, di, mono, and polyols. And it refers to the carbohydrate content of certain foods and how they're digested. If you're not having success with the typical foods, reducing beans, cruciferous vegetables, etc., looking at the low FODMAP diet specifically can be a very effective way to target what's causing you to have the symptoms versus somebody else. And I mentioned here that it's sometimes helpful to do this with guidance from a dietitian. Certainly us in the gastroenterology world are happy to talk about these things, but dietitians are specifically trained to talk through these changes and these strategies with patients. It can be very, very helpful. Next, let's just talk about what you can do from a lifestyle and potentially medication perspective. So as I mentioned, aerophagia is a source of gas. It's important to eat slowly and avoid swallowing excess air when you do. This means, no more eating on the run. Life is hectic, but sometimes it's important and helpful to sit down, chew thoroughly, eat your meals slowly. Sometimes walking after meals can help to move gas around in the system, help you to expel it more easily, and potentially help you to expel it more regularly so that it's not building up and causing you a problem when it's socially uncomfortable. And then how about medications to consider? Well, this table shows you some of the common ones that are available over the counter. The first one is lactase. So this is going to be like your Lactaid type supplement. It breaks down the lactose protein, sugars, It's specifically for people with lactose intolerance, but it's something worth testing if you're not sure if that's what's bothering you. Alpha-galactosidase is another enzyme supplement that you'll find, or you can find this over the counter. This is meant to break down complex carbohydrates and reduce gas from beans and cruciferous vegetables. Probiotics is a category that people often get a lot of enthusiasm for, and it's possible that this may help modify your microbiome and modulate the gas-producing bacteria in your system. Lastly, simethicone. So this is found in medications like Gas-X, and what it's meant to do is reduce the surface tension of gas bubbles in the body, making the gas easier to expel rather than spreading out through your digestive tract. Now, I do want to make an important point that while all of these medications in different forms are available over the counter and I think worthy of a trial, the evidence to support their use in this area from an evidence-based medicine perspective is actually fairly limited. But nonetheless, we think that they're unlikely to hurt you and so worth a try. So I want to leave you with a couple of take-home messages. First, importantly, gas is normal. Like I mentioned, we may pass gas 10 to 20 times a day. This is to be expected and is a normal part of digestion. However, bothersome symptoms can occur and they can be managed. How do we manage them? First, you want to track your triggers, specifically dietary triggers. Adjust your diet accordingly and use simple remedies, eating more slowly, walking after meals. Lastly, speak to your doctor. If you're worried about it or you're not having the success you want, feel free to speak to us in the clinic about it, raise it as an issue. There's no need to be embarrassed. Certainly, if you have the alarm features that we spoke about, you'll want to bring that up. But even if it's just something that you're not able to tackle, it may be worth a conversation to see what you could be doing differently. So thank you for the opportunity to talk to you, and I hope this was helpful.
Hello, my name is Christopher Velez, and I'm the Associate Program Director for Functional and GI Motility Disorders at Massachusetts General Hospital, Harvard Medical School. And today I'm going to talk about a topic that can probably cause a shiver of embarrassment down anyone's spine. Any anal lumps and bumps, inflammatory, infectious, and other perianal dermatoses. These are my disclosures and conflicts of interest, none of which are relevant to today's presentation. To offer a brief outline for the rest of the presentation, first I'm going to start off with a case that helps to highlight how we address evaluations for the perianal dermatoses. That's just the medical way of saying bumps and lumps down there. I'll offer some examples of these conditions as well as how they're diagnosed and how they're managed, and they broadly will break down into different categories, including inflammatory-related ones, infectious ones, and potentially sexually transmitted ones. And I'll explain what I mean by potentially there. And I'll wrap up the case and give you some guidance as to how to discuss a examination regarding this very sensitive part of the body with anyone who's taking care of you. As a physician, particularly one who focuses a lot on teaching, I often find that the cases that stick with me are the ones that keep me learning and keep me hungry to try to offer better care. So I have a patient who's 23 years old. He's a man, presents for evaluation of right lower quadrant abdominal pain. So that's abdominal pain right near where the appendix is, and occasionally bloody diarrhea. Symptoms began 6 months before the visit with me. This was associated with a 5-pound, 2.2 kilogram weight loss. He had blood work done recently during a primary care visit, which showed slight anemia that was suspicious for chronic inflammation, meaning that it didn't seem like there was a lot of evidence on the complete blood count to suggest a lot of blood loss, but definitely some, as well as some signs that perhaps the blood system was not responding well to an inflammation-related process. And in order to evaluate this further, the patient agrees to a colonoscopy to directly evaluate what's happening. It was a busy clinic. Oftentimes, gastroenterologists can sometimes have to see 16, 20, 24 patients in a full day. And you forgot to do a rectal exam, which in my mind, when I'm teaching trainees, any blood from down there requires a rectal exam to make sure you're not missing something important. And as you reach for the doorknob, the patient states, "Doctor, I have something embarrassing I need to show you." He comments that he's had some bumps around his anus for some time. He assumed that they were hemorrhoids. That's what he was told by other people. Physical exam is remarkable for some tenderness in the right lower abdominal quadrant. During a chaperone examination, since patients should have the right to have a chaperone if they want to during a physical exam in such a private area, during a chaperone examination, the following findings are encountered with these bumps right in the cleft in between the two buttocks around the anus. So the natural thought that I have as a doctor when I see that is what is happening and what needs to be done next. So when you think about any lumps and bumps when it comes to any part of your body, but particularly in a very private and sensitive part like the anus, history is key. How long have the bumps been there? Are there any other associated symptoms? Were there any exposures to illness that could potentially explain why these bumps may have developed? Characterizing the lesion type and size, I'll show that in a diagram because not all lesions are created equal. Some small things may be very dangerous. Some large things may be benign or not dangerous, but enough to cause an impact on quality of life. Obtaining further history, and in some respects, what is more challenging for us as physicians, obtaining a sexual history, because a lot of practices as it relates to sex, as it involves the anus and the rectum, are highly stigmatized, and people are often afraid when they bring them up with their doctor that they'll be judged for a particular sexual practice that they have. I am thinking about when someone's complaining about bumps and lumps around the anus is further diagnostic testing. In this case, I had described doing a colonoscopy, but do I need to think about doing any cross-sectional imaging? And that refers to getting a CAT scan or an MRI, or should I get a plain X-ray? Should I get some additional blood work? Should I get some additional stool testing? And what I'm thinking about as a physician is when we are thinking about the potential diseases that patients may have, we tend to prioritize what is most common, what's least common, what's most lethal, what's least lethal. And every bit of information in our internal algorithms moves certain diseases up and moves certain diseases down. And in many respects, the physical exam and the history helps us reorder what we think the most common, most likely disease is, what the second most likely disease is, et cetera. And when it comes to thinking about bumps and lumps anywhere in the body, they could be as relatively benign but nuisance conditions like eczema, or they could be something as severe as melanoma and skin cancer. So what I'm trying to think about as a doctor, and what you all should be thinking about in terms of being patients, is what is causing you concern, and oftentimes telling us to slow down and say, hey, actually, I'm concerned about this. There's a melanoma skin cancer history in my family. I've had a lot of sun exposure. I'd like to double check what this is. Can we just take a couple minutes to see what we need to do about that? And doctors, when they don't do that, it's not necessarily because they're trying to get you out the door, but they do have some time pressures of their own that they're trying to process. So this is a slide which shows different ways in which physicians will characterize lesions. The print is too small, but I will go through what each of these things are. But basically, where gastroenterologists face a deficit is dermatology is a separate medicine discipline compared to internal medicine. Gastroenterologists have to all go through internal medicine training, so we're learning how to take care of respiratory diseases, take care of heart diseases, take care of the lungs, take care of other parts of the body. Skin is a very big blind spot for gastroenterologists. So we sometimes feel a little nervous when we're describing abnormalities because we don't have the same training that our dermatology subspecialty colleagues spend years trying to get. So lesions can be flat, like a macule. They can be nodular, which I think people would intuitively know what a nodule means. They can be papule, which is sort of a little bit larger and raised. They can be pustules. They can be plaques, which are flatter lesions. They can be vesicles. They can be ulcers. They can be fissures. And these are the terms that you may see if, let's say, you're getting an examination for lesions around the anus, that you may see a gastroenterologist reference because it signals to other colleagues this should be drained, this should be biopsied. It gives us a sense of communicating from specialist to specialist what we need to do in terms of managing these different conditions. So this slide shows a pattern of distribution that is associated with other skin conditions. Basically, all the conditions I'm going to highlight as lumps or bumps in the anus are conditions that sometimes can be found in other parts of the body. And oftentimes when we make different diagnoses, it's not just looking at the lesion itself, it's looking at where the lesions are in the body. So if there are lesions in the flexors, or sort of the inner part of your arm or the back of the knees, that may reflect eczema. If there are lesions on the opposite side of the arms and legs, that may represent psoriasis. Other lesions, if they're present more in the scalp, may represent seborrheic dermatitis, and other lesions may reflect some type of photosensitivity or some damage related to the sun. So why this is important: as a gastroenterologist, I unfortunately have a laser eye focus on thinking about the GI tract, thinking about the esophagus, the stomach, the intestines, the colon, the liver, the pancreas. That's a lot of organs I'm worried about. I'm not necessarily thinking about the skin, but if the skin lesion that is around the anus has a pattern of distribution that's reflected in other parts of the body, then that will impact the type of referral I make, as well as the type of management I will consider for the particular complaint, even though it's brought to me from the perspective of what it looks like around the anus. So inflammatory lumps and bumps around the anus can consist of things like contact dermatitis, seborrheic dermatitis, atopic dermatitis, psoriasis, vitiligo, Crohn's disease. Except for the last one, I think some of these are conditions that some of you may be familiar with that impact the skin of other parts of the body. Infectious lesions that can cause lumps and bumps around the anus, perianal abscesses or infection collections, fungal infections, other bacterial infections, and that can also cause lumps and bumps to exist around the anus. And examples of perianal dermatoses that may be potentially sexually transmitted include herpes, HPV, gonorrhea, chlamydia, syphilis, mpox, and molluscum contagiosum. And the reason why I mention potentially is that sometimes it's not actually related to penetrative intercourse. It could be simple tracking. For example, if someone has an HPV infection on their finger, they're wiping themselves, it causes a lesion to form in the anus. The physician may be primed to think, oh, there must be something related to anoreceptive intercourse. Not necessarily the case, even though it involves the skin around the anus. And I mention that in particular because a lot of patients feel shame when it comes to having sex. And if you're having sex in a way that involves the anus, you may be even less likely, you may be more concerned, less likely to discuss that with the doctor with the fear that you're going to be stigmatized against. And what I also say is a lot more people are having anal sex than we'd realize. Oftentimes we tend to focus on men who have sex with men, but lots of people, including heterosexual couples, have anal sex. I hope you all who are watching have had your most recent meal, because some of the images that I am showing are perhaps not the most appetizing to look at, but I think they're important to show you because they may be things that you've noticed on your body. What I would recognize as well is there's an increasing recognition from the diversity perspective in medical care that things may look one way on one skin tone and not on other skin tones. So sometimes if things don't look like the way that they look, and I'll be honest, a lot of the times the images that exist in the literature are usually drawn from people of European ancestry. It may be that it doesn't look this way just because you have darker skin or a different type of skin type. So when it comes to thinking about contact dermatitis, usually the symptoms are red, itchy rash caused by contact with an allergen or irritant, usually physical exam or review of recent exposures, new detergent, new clothing, new garments, new exercise routine. And then you're trying to avoid the irritant, use moisturizers and steroid creams to help get rid of the worst parts of the inflammation. Seborrheic dermatitis is a rarer reason for you to have a lump and bump around the anus, and usually would be paired with something you have more in the sun-exposed portions of the skin. Scaly patches, red skin, dandruff-like flakes. Physical exam is the way that you make the diagnosis, but sometimes you need a skin biopsy, and sometimes you need medicated shampoos and antifungal creams in order to try to see if you can get rid of any potential source of the that is driving the development of the lesion. Continuing for other types of inflammatory lumps and bumps, eczema is itchy, dry, red patches on the skin. Physical exam and medical history are the main ways that we diagnose it, although sometimes we'll need to have a biopsy in order to double check that that's the correct diagnosis. And you're thinking about moisturizers, steroid creams, and avoiding triggers, stress, or things like that that may cause an eczema flare to occur. Psoriasis, it's thick red patches with silvery scales that will be present in other parts of the body. Physical exam and skin biopsy are the main ways in which one would consider uh, trying to find a way to diagnose this condition. And sort of similar as to the other inflammation-related anal lumps and bumps, it's steroid creams, maybe some light therapy, maybe some immune suppressing drugs to get that degree of inflammation under control, particularly if it's bothersome. Crohn's disease is another more GI-specific type of inflammation. Crohn's disease is a disease that can affect anywhere in the GI tract from the mouth all the way down to the anus, typically impacting the end of the small intestine that's called the ileum, or the beginning of the colon that's called the cecum. Here, what you're seeing are things that are called unfortunately, I'm stuck with the terms that exist. They're called elephant ears because of their appearance and how large they are. I wish there was another term for it. They can be painful, they can be painless. They're bumps and sores that can be near the anus. You usually make the diagnosis with colonoscopy, with CAT scans to see if there's any involvement in other parts of the GI tract, and you may need to biopsy, although this finding, for example, in this picture here, with inflammation in the end of the small intestine and the colon, I wouldn't need to biopsy. I know this is most likely related to Crohn's disease, and really you're focused on trying to get the Crohn's disease under control. When we think about the infections, candidiasis reflects a fungal infection, and those can be very itchy red rashes that may have white patches. You may need to make the diagnosis by scraping the skin to see the fungi under a microscope. And you're thinking about antifungal creams or pills in order to get rid of that type of infection. Tinea ringworm, you have these red, scaly, ring-shaped rashes with itching. You may also need to do a skin scraping in order to be able to make the diagnosis, and it's sort of the same thing. You're thinking about things that are going to be antimicrobial and try to kill the organism that's responsible for that infection. Hidradenitis suppurativa is a very aggressive abscess type disease process that can result in painful lesions happening around the anus. Sometimes these require extensive surgical resections. Other times they require drainage and antibiotics. This would be something that would often work with a colorectal surgeon or a surgeon of some type in order to make sure they weren't making things worse by not thinking about the disease process as a whole. When we're thinking about the potentially sexually transmitted infections, herpes can cause a painful blister or sore around the anus. You may diagnose it with a blood test or a swab test, and then there are herpes-specific antiviral therapies that can be used if there is a widespread infection. HPV, so people sometimes call this warts. This can be related to sexual activity, but also related to manipulation of this part of the body from another part of the body that's infected with HPV. I like to let all people listening to this lecture know that, at least in the United States, you're now approved for HPV vaccination up to the age of 45, both men and women. So even if you have a history of warts, or if you don't, I urge people to get vaccinated, because this helps. The strains that are available now in the HPV vaccination can prevent or make it less likely for these warts to form, but also head and neck cancers that can also be caused by HPV infections. And then sometimes you need topical treatments or surgery to remove these lesions. Gonorrhea, chlamydia generally will be only possible through penetration of the anal rectum, either with an unclean toy or anoreceptive intercourse. And usually what will happen is actually there's no symptom. So people who are having sex in any part of the body, that part of the body may needs to be swabbed. So oftentimes when men undergo STI or STD, sexually transmitted disease screening, they only focus on infections in the urethra. But then if one is engaging in anoreceptive intercourse or oral sex, you can have gonorrhea, chlamydia infections there. And what you may have is some discharge or mild anal pain. And generally, you make that diagnosis by getting a sexual history. You can do an anorectal swab and you treat these lesions with antibiotics. Syphilis, sores near the anus, can have rash or fever later on. You would get a blood test for that, and then you would need a penicillin injection in order to treat that. Mpox is a newer virus that was causing a spate of infections, which could be present around the anorectum. A couple years ago, there's been widespread vaccination push, and sometimes you take antiviral therapies as well to remove that lesion. And then molluscum contagiosum is caused by a virus. It can result in these bumps that are present. Generally, they go away on their own, or you freeze and scrape it off. So going back to the case, the lesion that I showed you was an elephant's ear lesion related to Crohn's disease. And based on the fact that this gentleman was complaining about right lower quadrant pain, that's around the area where you would expect Crohn's disease to be present, and the fact that there was a slight anemia made me think that the most likely diagnosis was Crohn's disease. Doesn't really change my pattern of evaluation. I still would do a colonoscopy, but I may, in this instance, consider a CAT scan. I may consider doing other stool testing to help me track disease responsiveness in order to gauge in the future how effective treatments are that I'm recommending. And sometimes inflammatory bowel disease, Crohn's disease is an inflammatory bowel disease. Sometimes that can result in impacts in other parts of the body, in the eye and joints and skin. So seeing this picture, paying attention to that lump and bump may prompt me to consider referral to another specialist for evaluation. So what I would say in conclusion, the diseases that involve the anus are inherently icky. People are inherently embarrassed to talk about them. It's okay to be embarrassed, but you shouldn't be made to feel embarrassed. And I think that's a very important distinction. Doctors face a lot of pressure for time. Ask us to slow down if you have a concern, particularly if it involves a sensitive body part like around the anus. Insist on examination of the area. Don't just have a doctor say, oh, it's probably hemorrhoids without examining the area. And what I would say is we're not good at skin examinations. So if you are wondering if you need a second opinion, I think your gastroenterologist would be willing to refer you to see a dermatologist or colorectal surgeon in order to make sure that the correct diagnosis is not being missed. Thank you.
Hi there, my name's Maddie Berschback. I'm one of the gastroenterology fellows at Massachusetts General Hospital. I'm going to be talking to you today about the aging gastrointestinal tract. We're going to be talking about an overview first of gut health. What are some changes associated with the GI tract with age and symptoms associated with aging, as well as lifestyle and environmental factors that can affect this, and what you can do to slow down gut aging. First, what do we mean when we say the gut? We're talking first about the primary gastrointestinal tract, or lumen. We're referring to the esophagus, stomach, small intestine, which includes the duodenum, jejunum, and ileum, as well as large intestine, which includes the colon and the rectum. We're also referring to the accessory organs that help with digestion. These include the liver and gallbladder, as well as the pancreas. Additionally, we include the enteric nervous system, or the nervous system that helps to control the movement of the intestinal organs, as well as the microbiome. All of these things together help to comprise the gut. What are some of the functions of the gut? So first, the intestines help to absorb your nutrients. They act as an immune barrier to protect against infections. And as we know, they produce waste and help with elimination. The microbiome is comprised of trillions of bacteria and microbes, and all of these together help to support digestion and absorption, as well as immune function. It also performs various neuro, hormonal, and metabolic functions in the body. What are some changes in the gut function associated with aging? First, we can have slower movement or motility of the intestines. Aging affects the gut nervous system or the enteric nervous system. These can cause effects such as slowed stomach emptying, which can lead to earlier fullness than usual. And food and waste can generally move more slowly through the digestive tract. Changes in taste and swallowing can also occur. Taste can become less sharp, and swallowing can become more difficult with age due to weaker esophageal muscles. Lower stomach acid over time can also affect nutrient absorption. There can be changes in the gut lining with age, where the protective barrier that's normally there can become weaker. Nutrient absorption can also be affected due to less intestinal surface area, also known as the villi of the intestines. There can also be changes in the microbiome, such as less variety and balance or diversity of the types of gut bacteria. These can be due to diet changes, immune changes, or illnesses and medications used over time. Overall, these can lead to weaker gut immunity, where the lining of the intestines becomes thinner and less protective. This can lead to increased infections over time with age. And the immune system overall, we know, decreases with age, which is a concept called immunosenescence. So to summarize, aging and your gut, what you should know, that there might be slower motility because the movement of food and waste slows down. There's less acid because stomach acid decreases over time. The thinner gut lining or protective barrier of the gut becomes affected with age, and changes in the composition of the gut bacteria and overall reduced absorption of nutrients can occur. What does this mean for you in terms of symptoms or signs of aging with your intestines? So the slowed or changed motility can lead to difficulty swallowing, earlier fullness due to slower stomach emptying, and overall slowed GI transit, such as constipation, bloating, or fullness. Weakening of GI muscles over time can lead to difficulty swallowing or fecal incontinence, and decreased nutrient absorption can lead to deficiencies. Decreased surface area of healthy lining of the intestines, as well as decreased stomach acid overall can affect absorption of nutrients. Increased disease risk due to immune changes include things such as colorectal cancer risk, which increases with age. Infection risk also increases with age, and there are some associations with GI disease and neurodegenerative diseases over time. So what can be done on your part to help support your gut as you age? Many factors influence the aging of the gut, including genetics, but as well as lifestyle environment, dietary habits, physical exercise, other diseases, and exposures to medications. So some of the things that you can impact are your diet, including prebiotics such as fiber from vegetables and other foods, and probiotics like fermented foods or supplements can help support your microbiome. Limit processed and ultra-processed foods and minimize alcohol, which helps to support your microbiome's health. And minimizing unnecessary medications, particularly antibiotic exposure, but also medications like non-steroidal anti-inflammatory drugs. Outside of the microbiome health, to help support overall gut health, staying active as you age is very important. As well, managing stress and sleep over time to help support digestion, limiting harmful habits like avoiding smoking and heavy alcohol use, which can not only impact the gut bacteria, but also damage the gut lining. Using medications wisely, including antibiotics, as we said, but also antacids and non-steroidal anti-inflammatories, and stay on top of screenings such as colonoscopy, but other age-appropriate care. Thank you so much.
Hi, welcome back. As you know, my name is Cecile Rooker, and I'm the president and executive director for the International Foundation for Gastrointestinal Disorders, or IFFGD. I hope you've enjoyed the talks that you've just heard about the lower GI tract of your gastrointestinal symptoms. Today, we are focusing completely on the lower GI, and you've been hearing from presenters from all over Boston. There's 4 different hospitals, as I mentioned earlier, all related to Harvard, right here in beautiful Boston, Massachusetts. As always, I'm super thrilled to have with me two wonderful gentlemen here who run the whole show around here. Dr. Kyle Stoller is the Director of Motility at Mass Gen, and also Dr. Brad Kuo, who is the Director for the Center of Neurogastroenterology Health at Mass Gen currently, and the incoming Chief of GI at Columbia. So we're thrilled to have you guys here with us today. And now that we've seen these fantastic presentations, which are wonderful on their own right, I've been taking some notes and I have a few questions. Do you guys want to indulge me?
We're happy to. Yeah.
All right. So the first thing that I want to talk about is so in our talk on bowel urgency, so we heard the term migrating motor complex. And I'm wondering if you could explain that to me, because I feel like that's something that's really important to the GI symptom and something that we don't even realize is happening.
Actually, I think Brad should take this one because he taught me his passion for the migrating motor complex.
All right.
You're okay. So the migrating motor complex is this very big giant contraction wave complex that's generated periodically in the GI tract. It usually happens after you've eaten a meal and you're returning to what we call the fasting state, where this every 90 minutes in human beings, this giant wave complex is generated in the proximal gut, and the stomach then sweeps undigested material and other material through the GI tract all the way into the colon in ways of just moving material over. But there are certain things that we have in our bodies that also are precipitated by normal actions. So when we eat, we also generate a large migrating motor complex, not originating from the upper GI tract, but in many ways lower down to make way for the GI tract for the stuff that's coming from the meal that you just ate. And so this giant wave normally happens, for example, if you have breakfast in the morning or you're having your morning coffee. It's quite common for people to feel an urge to go to the bathroom. And that is normal. That's what oftentimes precipitates their daily bowel movements. But in certain situations, that's natural phenomenon of generating that migrating motor complex to make way for material in the colon to happen may feel abnormal, may feel of higher intensity or higher urgency, precipitating symptoms and questions about what's going on.
Fantastic. Thank you so much. So during our talk on constipation, they talked about the SITSMART study and that you would take those capsules and then 5 days later you would get a x-ray. And if more than 5 capsules were still left, that would be considered abnormal. So does that mean that when we eat a meal, that we would anticipate that it would be 5 days before our body fully digests that and eliminates that? Because so often people will eat a meal and then within 30 minutes to an hour, they feel very, very sick. And so they immediately attribute the sickness to what they've just eaten. Is that a correct response, or is it more later on that you would feel something if you ate something that was contaminated?
Yeah, I think it's complicated. I think, of course, when you eat, the food goes into the stomach. It may spend up to 2, 3, 4 hours in the stomach, then before emptying into the small intestine, at which point it's going to spend several hours in the small intestine. And then the waste that hasn't been absorbed is actually going to go into the colon and can spend several days in the colon. So you can imagine things can happen anywhere along that pathway. So as you said, a SITS marker up to 5 days. Yes, things can happen up to 5 days with food that you've eaten, but it can also happen immediately afterwards. So it really depends on what you've eaten, how it's interacting with your digestive tract. And if we're thinking about infectious types of things, bugs that you might have ingested, it may be the type of bug which may hit you sooner or later depending on what you're working with.
So important to talk to your doctor about when the symptoms started in reference to what you're diagnosed with. Fantastic.
Okay. Interesting thing about the non-digestible markers is there are foods that people eat that are non-digestible too. Corn, other things, and they notice these things pass in their bowel movements. I know you talk about the core test at times. Maybe you can comment about that.
Yeah, I mean, I think everyone's had the experience of seeing something in the stool that looks like it's made it through unchanged, right? And of course, humans don't have these enzymes that we need to digest plant cell walls. So anything that we eat that's a cell wall, and that's like the skin of a blueberry, the outside of a corn, anything like that, onion skins, anything will actually come out unchanged. We still absorb it. We absorb the digestible parts that are inside, but we will often see those things come out in that stool, and that's very normal. And so that's something I often hear from patients is, I can see these skins and things in my stool. Does that mean I'm having a problem with malabsorption? And the answer almost always is no, that's very normal. But you can imagine if you're having looser stools, they're going to be more likely to show up, and then you're going to say, wow, I'm not absorbing things.
Awesome. I hadn't really thought about that. Thank you. So let's move on to antispasmodics. So that was mentioned this afternoon, and that you can have them take them over the counter. So can you maybe explain to us what some examples of those are and where they might find them, and exactly what an antispasmodic is?
I think, your GI tract is coated with nerves, but it's also coated with muscle. And that type of muscle is a muscle that we don't choose to control, right? It's called a smooth muscle. And it's also the same type of muscle that's in our arteries and creates blood pressure and things like that. So that smooth muscle can spasm, and that can cause pain. And what antispasmodics do is really relax that spasm by relaxing smooth muscle. So some of the best antispasmodics are available by prescription only. Of course, depends on what country you're in, but here in the United States, definitely by prescription only. But there are sort of natural over-the-counter type antispasmodics as well, and I think probably the best example would be peppermint oil. Peppermint oil, which is available in sort of commercial formulations with brand names, but also in sort of generic type formulations. This is a great antispasmodic. It's available over the counter and something that anyone can try out without necessarily having to go to the physician and get a prescription.
Fantastic. I'm sure that's very helpful for people. So I want to talk about one of the last talks we just heard here today about anal lumps and bumps. Okay. So, a lot of people that we talk to here at IFFGD will say that, well, my doctor said it's nothing to worry about, but it bothers me. What can I do? The what can I do is so important to these folks. If it's something that's concerning to them, what can they do if it's completely harmless?
I think a good rule generally, I would say, is don't mess with the anus, which means that, surgeries and things like that, they can have prolonged recovery times. They can be quite painful. But it's important also to think about what's going on down there, because so many times patients will say, I have a hemorrhoid, right? And anything that's down there is sort of considered a hemorrhoid. And we've learned from the talk that actually there's more than just hemorrhoids down there. But just as a reminder, right, there are two kinds of hemorrhoids. There's internal, which tend not to hurt. They tend to bleed, and you can't really see them and generally can't feel them. And then there are external hemorrhoids, which are these sort of blue bulges that you see, which get a clot in them. They can be incredibly painful, but they tend not to bleed too much. So internal hemorrhoids can actually be banded. Almost a rubber band is put around them to allow them to heal. And that's something that's very useful when someone has bleeding. External hemorrhoids, on the other hand, generally they're only problematic when they have a clot in them, and then we really know them because they're really uncomfortable. In those cases, most of the time, those will go away on their own. Now, after a hemorrhoid has kind of resolved, an external hemorrhoid, right, that clot has gone away, you're often left with a little souvenir, and it's a little bump. We might call it a skin tag or something like that. And many patients may say, that skin tag is really bothersome to me. I need more time to clean up after a bowel movement. I don't like the way it looks, something. And then they can talk to a doctor about potentially getting it removed. But generally, my advice is leave it alone unless it's really bothersome to you.
But I would second that, that anorectal region is amazing in so many ways in that it can tell the difference between gas and liquid and solid stool. There's a very complex machinery that to figure this stuff out, to know when you need to go to the bathroom, when you want to hold it, and so this finely tuned machinery, much like an expensive sports car, can easily get out of whack. But the reality is trying to mess with this fine-tuned machinery, unless it's extremely dysfunctional, can put a lot of problems at risk.
Thank you so much. I know that there are many people, that have had hemorrhoids, and it's very common. It can be bothersome, so it's nice to know that they can resolve themselves. And if they don't resolve themselves, what are the options? What if that external hemorrhoid doesn't resolve itself?
Yeah, I think when an external hemorrhoid has a clot in it and it's big and painful and it's really bothersome to you, the sooner that you see a doctor, sometimes they can actually take that clot out and can immediately relieve the pain. For the average patient, I recommend just kind of warm water baths, just kind of relaxing, softening the stool as much as possible. In reality, it's important to keep in mind that hemorrhoids are veins that we all have. In fact, they help kind of maintain continence, meaning prevent us from having accidents. And so when people say hemorrhoids, it really means one of these veins has kind of lost its kind of tissue attachment that kind of prevents it from being a little bit floppy. And so hemorrhoids, when we mean it, is not that we have the veins, it's the veins, the sort of connective tissue, the supportive tissue has become floppy, and then they tend to come out and become more bothersome. So really, I say symptomatic hemorrhoids. And in general, we try and leave them alone. Really, really painful one, sometimes that clot has to be removed, but I think that's more the exception than the rule.
Fantastic. And when you say if we get to the doctor soon enough, so what is soon enough? So if I start feeling like my hemorrhoid is bothersome today, should I do the warm baths for 3 days, for a week?
Yeah, I
At
think,
what point would it be sort of like you should go in at this point?
I think the ironic thing is that the sooner you go in for a hemorrhoid with a clot in it, the better. But that's usually the hemorrhoids that are really painful because none of us really want a procedure on our anus unless we need it. And so usually within 48 hours to actually have that clot removed.
Okay.
Otherwise, once that clot is there and it's kind of set up shop, it's actually more dangerous to try and remove it. And it's best just to deal with warm water baths,
Right.
try and soften the stools, that type of thing. So I think for the average person who encounters a hemorrhoid, really kind of taking a conservative approach to it is probably the best message.
But if it's extremely painful, within 48 hours, you should probably be talking to your doctor.
Yeah, I think if you've got really extreme pain in your anus, you really have to talk to your doctor because it's not just hemorrhoids. Fissures are another thing. Fissures are a small cut in the anus. That small cut is not a big deal, but underneath that small cut is this very sensitive anal sphincter complex, right? Which is the muscle that helps prevent us from having accidents. And that will spasm when there's an anal fissure. And that can often be incredibly painful. That's not an emergency, but there are things that we can do. Again, warm water baths, even some topical ointments that relax the muscle that can really relieve the pain.
Fantastic.
The key thing is that if you start having symptoms, don't put it off. There's a lot of conservative measures that you can actually do on your own, but do them early rather than letting it progress.
Fantastic. It's always good to tackle those symptoms early. Make sure that you don't let them go on without you trying to do something about it. You know your body. You know what is normal for you. And all of a sudden something doesn't feel normal, immediately try to figure out how you can tackle that. Do you need to see a doctor? That's a lot about what we're talking about this week with this program on GI symptoms. But the underlying meaning in concept here is that she should do something and do something early before it gets worse. I had that right? All right, guys. I have one more question for the session. And that is about constipation. Constipation is so common. So many of us, I can't think of one person in my life that has never been constipated, right? And one of the things that they spoke about was many different causes for constipation that were very structural and part of our bodies. And they mentioned that there could be other causes as well. And I know that our program today was talking about your body and what might cause that constipation and make you want to go to the doctor. But they also said that there were other causes. They could be medications, other conditions. Can you guys maybe expand a little bit more into that? So those viewers at home, maybe that have constipation might have a better idea of what these medications might be, what these other conditions might be. So they might know a little bit more about what's happening if they're feeling constipated.
I think, as you said, Cecile, the average patient that develops constipation, it's really an innate issue with themselves, that chronic constipation in particular, constipation that's been going on, it's bothersome for 6 months or more. Often this is sort of how we're wired in the way that our nerves and our muscles work in our colon. But in reality, when we think about other causes of constipation, one of the biggest causes is actually our fault, which is caused by medications that we might prescribe. And I think the number one offender, if we look worldwide, are going to be narcotic or opioid type pain medications, right? These are pain medications that by definition will slow the bowel down and can cause quite a bit of constipation. But there are lots of other medications, even some high blood pressure medications, certain antidepressants, lots of medications, iron being one of the classic offenders, antihistamine, calcium, even antacids, certain antacids. So I think it's often good that we sort of look in the mirror and say, well, what on my medication list have I started recently that might be contributing to my constipation? Because there's a lot of hidden medications out there that can slow things down. Now, less common, I think, for the average patient with constipation. It's very rarely a serious medical problem. But there are certainly neurological conditions, for example, Parkinson's disease, where constipation can be a big manifestation of it. Now, all the patients that are having really bothersome constipation, very few are going to actually end up having Parkinson's disease. But this is another medical cause that we think about: Parkinson's, ALS or Lou Gehrig's disease, multiple sclerosis. Anything that affects the nerves can also affect the bowels and how they operate.
I mean, not to be alarmist, but we have also done work showing that GI symptoms can frequently precede a lot of these more devastating neurological diseases. So it's not to say that you need to rush out there and consult your neurologist if you have a little constipation for some devastating neurological disease. Just understand that these are all related to each other. Your GI constipation can be managed, but you should be paying attention to other parts of your body, and then bring it to the attention of the healthcare provider if things start evolving in other aspects as well.
Absolutely. So having an open and honest conversation with your healthcare provider about all the things going on in your life is really important, especially when you look at some of these symptoms that, people think everyone gets diarrhea sometimes, everybody has constipation. These are things that are common, but if they are bothersome to you, then you should absolutely be talking to your doctor about it. If you feel that there are other things happening in your body at the same time, make sure that you're having that conversation with your healthcare provider. So that's all the time we have today for lower GI symptoms. I hope you've enjoyed our program here in Boston as we work with 4 different hospitals associated with Harvard to go through all of these GI symptoms. It's not an exhaustive list. So if there are symptoms that you feel that we have missed, please make sure that you reach out to us and ask us about those. And we will definitely be able to get back to you with some information about maybe a symptom that you have in your GI tract that is bothersome to you or you have questions about. Email me and let me know, okay? So the email address is iffgd@iffgd.org. Again, my name is Cecile Rooker. I am the president and executive director for the International Foundation for Gastrointestinal Disorders. We are here with Dr. Brad Kuo and Dr. Cal Stoller, who have been amazing to put this program together and generous with their time to sit down and help us to hash out some of these lasting questions that we have on the programs. So we hope that you have enjoyed this program and that you will come back and see us again for our next and final session, which will be the alarm signs that you might be experiencing in the GI tract, things that you should really be concerned about. So please tune in again as we complete the Nancy and Bill Norton Patient Educational Series event on GI symptoms.